Okay, you can start now.
Okay.
Hello, ma'am.
Hello.
You can start now.
Okay. So first we are going to start with NSAIDs. Okay. First of all, NSAIDs are non-steroidal anti-inflammatory drugs and antipyretics with an antipyretic action and are and having analgesic, antipyretic, and anti-inflammatory actions that we can assume from the name itself. They are non-steroidal. Why they are called non-steroidal? Because the same appearing, similar eicosanoid depressing anti-inflammatory action is shown by steroids also, but it is different from the steroids. So hence to emphasize on it, we are adding a prefix non-steroidal in the name of the drugs. So they are called NSAIDs or non-steroidal anti-inflammatory drugs. They are having antipyretic action, that is reducing the temperature in fever. That's not occurring in normal individuals. It reduces the temperature only in case of fever itself. Okay. So they are non-narcotic, non-opioid, aspirin-like analgesics. And unlike morphine, they do not depress CNS and do not produce physical dependence. They have no abuse liability and are particularly effective in inflammatory pain. So we are used for dental pain. We are using it for the dental pain. Now coming to the mechanism of action. First of all, what's the basic mechanism of action of NSAIDs? Basic mechanism of action of NSAIDs. Simply in a one-line manner, I'll tell you that the simply NSAIDs, they inhibit the prostaglandin synthesis. Then, in order to understand the mechanism of action of NSAIDs, we have to understand the main actions of prostaglandins. Okay. Normally, we can see prostaglandins in our body all the time. All the time, some amount of prostaglandins are present in our body. They are particularly present for some of the normal functions. Some protective functions are there for prostaglandins. And in case of some stimuli, like, okay, in case of some stimuli like inflammation, some chemical stimuli, some inflammation, infection like stimuli, what happens is we need some additional amount of prostaglandins. For such an action, we need prostaglandins, and they are made from the membrane phospholipids. Membrane phospholipids are the normal component of our cell wall. Okay, so membrane phospholipid, when in case of some inflammation or a chemical and mechanical stimuli like inflammation, infection, etc., they are acted upon by an enzyme, namely phospholipase A. So, by the action of phospholipase A on membrane phospholipids, it is converted to arachidonic acid. So, what's arachidonic acid? It's a 20 carbon unit acid with 4 double bonds. Okay. And now, an important point in case of this is we already mentioned that NSAIDs are non-steroidal. Then, what is the action of steroids here? In this particular pathway, the action of steroids or corticosteroids is the inactivation of phospholipase A. So, which of the following, whether NSAIDs or corticosteroids have a better mechanism of inhibition of anti-inflammatory action, So, corticosteroids have a better anti-inflammatory action than the NSAIDs. Why? Because of this inhibition of phospholipase. Okay, so by the inhibition of phospholipase by the corticosteroids, we will block the start of the prostaglandin synthesis. And after that, what is the action of NSAIDs here? Hello? Hello? Can everybody hear me?
Yes.
Okay. Okay. So, while after the formation of arachidonic acid, there are two pathways will take place. One is the COX pathway and second is the LOX pathway or lipooxygenase pathway. LOX pathway is mainly involved in the anaphylactic reactions and LTB4, leukotrienes. Lipoxygenase pathway will give rise to leukotrienes, and leukotrienes are mainly implicated in the anaphylactic or hypersensitivity, type 1 hypersensitivity reactions. So they are drugs which inhibit the lipoxygenase pathways usually are drugs for asthma, asthma, etc. So respiratory action they have. So they inhibit the type 1 hypersensitivity reaction mainly seen in asthma. So the next pathway that we are concerned about now is about the cyclooxygenase pathway. By the action of cyclooxygenase enzyme on arachidonic acid, there are numerous things are produced. One of them are prostaglandins, thromboxane A2. Thromboxane A2 that is present in platelets. So that's an important point in antiplatelet action of some drugs like aspirin. And prostacyclins, that is PGI2, they are also inhibited. They are also produced by the action of cyclooxygenase in arachidonic acid. Okay. Now, coming to the actions of COX enzymes, COX or cyclooxygenase enzyme. We have three types of COX enzymes, that is COX1, that is having a constitutive action. As I have already mentioned, we know that prostaglandins are present in our body all the time. So, that is produced by the COX1 enzyme. That is a constitutive enzyme which is present all the time in our body. And next enzyme is COX2 enzyme. COX2 enzyme means that is an inducible enzyme. Inducible enzyme means it is produced only in times of some emergency, i.e. In inflammation, etc. In inflammation, we need additional prostaglandins for the support of the body. For that, COX2 is an inducible enzyme and that is produced in times of inflammation. And another enzyme is there, that is COX3, that is having an antipyretic, analgesic action and no inflammatory action. This is because COX3 is constitutively seen in brain. And brain, it is having an antipyretic, that is fever reducing action, analgesic or pain killing action or pain reducing action, but it is not at all involved in the inflammatory reactions. So COX3 is not implicated in inflammation. That's why the main group of drug involved in inhibition of COX3 is paracetamol. So that's why we are calling it as analgesic antipyretic with no inflammatory, almost nil inflammatory action. Okay. Now, just a word before the class, we are coming to the classification. First group of drugs that are produced in, that are found in the NSAID group is non-selective, irreversible, non-selective COX inhibitors. That means they inhibit both COX1 and COX2. All COX enzymes, that is COX1 and COX2 mainly, they inhibit irreversibly. The only one drug is implicated in such type of such group, that is aspirin. That's why aspirin is having more side effects when compared to the other NSAIDs. Okay, so why? Because there is no need to inhibit COX1 enzyme for normal functioning or to reduce inflammation. We only have to reduce the amount of COX2 in our body. Okay, now coming to the classification. Classification we have, first is non-selective COX inhibitors. That means COX1 and 2 both are equally inhibited. In its group, only one drug which is irreversibly inhibiting all the both COX enzymes like COX1 and COX2. That is aspirin. Aspirin is always called acetate salicylic acid. It's an acidic type of drug. And rest others are reversibly inhibiting the COX enzymes, that is COX1 and 2 mainly. And second group of drugs is preferential COX2 inhibitors. Preferential. Preferentially they inhibit COX2. That is what we need. No, that's what we need. We don't have to inhibit the COX1. And when the inhibition of COX1 also occurs, there will be a lot more side effects. Okay. In order to avoid that, we made next group of drug, that is preferential COX2 inhibitors. That involves, they inhibit some phenac word, phenac. And there's a mnemonic. Preferential, we can This Fe is also seen in diclofenac, aceclofenac. That way we can remember them. And also nimesulide, diclofenac, aceclofenac, meloxicam, itodolac, etc. Only 2 is needed for the exam usually. Usually they will mention you to write only two examples. Okay, for the classification purpose. Next is selective COX-2 inhibitors. Selective COX-2 inhibitors means almost they do not inhibit the COX-1 enzyme. So they are basically COX-2 inhibitors, selective COX-2 inhibitors. They usually end with COX-CYP word, CYP. And next is that we have already mentioned that COX-3 inhibitors, that is having analgesic antipyretics with poor anti-inflammatory action. Only 2 are there. That is mainly paracetamol and metamizole, etc. Okay. So these are their chemical names: salicylates, propionic acid derivatives. Main classifications based on this inhibition of the COX enzyme by the mechanism of action, and we can classify it by the chemical groups also. Now, let's brief the things I have told you before. First is NSAIDs. They block the prostaglandin generation. And prostaglandins, prostacyclins, that is PGI2, thromboxane A2 are produced from arachidonic acid by the enzyme cyclooxygenase or COX. And COX, we have already mentioned that like a constitutive form, that is COX-1 is seen, and inducible form COX-2. And most NSAIDs usually inhibit the, that is non-selective COX inhibitors. COX-1 and COX-2 are non-selectively inhibited in most of the drugs. And aspirin covalently binds COX-1 and COX-2 irreversibly. That's the only one drug that is irreversibly acting on the COX enzymes. And other NSAIDs are competitive and reversible inhibitors of COX. What do you mean by competitive inhibition? Competitive inhibition means we can reverse the action by additional amount of that particular drug. Okay. Another drug then given in excess that can inhibit the action of the previous drug. That's what we call as competitive inhibition. So what are the actions of NSAIDs? First and main action, we are using it for the pain relief, that is analgesia. How this analgesia occur? This NSAIDs block the pain sensitizing mechanism induced by bradykinin, TNF-alpha, interleukins, and other pain-inducing substances, primarily by inhibiting the COX-2 enzyme, which is involved in inflammation. Next is the anti-pyresis action. Anti-pyresis action, that means what? It can lower the body temperature in fever, but it do not cause hypothermia in normal individuals. And fever during infection and tissue injury, it is produced due to the generation of pyrogens. Pyrogens means fever-producing agents, including interleukins, TNF-alpha, interferons, which induce the PGE2 production is mainly for the pain production in hypothalamus, and thereby raise its hypothalamus is the homeostatic mechanism. That is, the body temperature is usually regulated by the action of hypothalamus in brain. So it will set the normal temperature in our body. Here, when fever occurs, the hypothalamus, the temperature is set to the higher point, and the NSAIDs block the action of this particular pyrogens. These pyrogens, when in case of fever, they will act on hypothalamus to raise the set temperature of hypothalamus. But by inhibiting this pyrogens, NSAIDs will relieve from fever. That's the reason for the antipyretic action of NSAIDs. Next is that we already main uses anti-inflammatory, that is mainly by the COX-2 mediated enhanced PG synthesis inhibition at the site of injury. And another miscellaneous uses are also there. It causes the closure of patent ductus arteriosus. Okay, patent ductus arteriosus closure. For premature birth, we require this closure of patent ductus arteriosus should be closed. And also it inhibits the uterine contractions. So in uterus, the prostaglandin has its action as contractions and it induces labor. So as an inhibitory action to PG synthesis, this NSAIDs will cause the delay in labor. Therefore, NSAIDs is not good in pregnancy. In pregnancy, NSAIDs can cause delay in labor. premature closure of ductus arteriosus. That's also a side effect in pregnancy. In pregnant females, we do not want to prematurely close the ductus arteriosus because it's a functional thing. But in case of pregnancy, we can safely prescribe paracetamol. Paracetamol is the safest NSAID in pregnancy. Okay. Also, we know that NSAIDs will reduce the inflammation, but it is not implicated in inflammatory bowel disease. Okay. Now coming to the side effects. So there is an effect, there is a side effect also. Okay. First side effect is that's always seen in almost all the drugs, nausea and vomiting. And second is peptic ulcer. Why this is having a peptic ulcer producing activity? Because prostaglandins are protective of stomach and COX-1 enzyme is seen in the stomach cells. By inhibiting irreversibly, that mainly it is most commonly seen in aspirin. Why? Because COX-1 and 2 is inhibited by aspirin. Most commonly, it is seen with aspirin. So, peptic ulcer production is the main side effect of aspirin. Most commonly, it is associated with aspirin. COX-1 enzyme stomach is protective. It will produce a reduction in hydrochloric acid, normally seen in the body, and also production of some protective mucus barriers, etc. in the stomach. And that is inhibited by the irreversible inhibition of COX enzymes. Next is allergic reactions can occur. Next is Stevens-Johnson syndrome. Fixed drug eruptions can also be seen as the side effects of NSAIDs. And usually they are nephrotoxic. And the nephrotoxic effect produced by these NSAIDs, they are called by a name, analgesic nephropathy. Next is we have to mention about two basic NSAIDs. That's very important for the exam. First is aspirin and second is paracetamol. That's these two are most commonly asked in exams. Okay. So, what is aspirin? We have already mentioned that aspirin is an irreversible inhibitor of COX-1 and COX-2 COX-2 enzymes, both COX enzymes. Okay, this are always called acetyl salicylic acid. Acetyl salicylic acid. And aspirin, since it is an irreversible inhibitor, it is also called hit and run drug. Because even after the cessation of aspirin, we can see its actions. Some actions will be persisting because of the irreversible inhibition of COX enzymes. And it is one of the oldest analgesic anti-inflammatory drugs. And the mechanism we have already mentioned, that is irreversibly binds and inhibits both cyclooxygenase, that is COX-1 and COX-2. Coming to the pharmacological actions, aspirin is a weaker analgesic than morphine, obviously. It's an opioid analgesic. Morphine is an opioid analgesic. Obviously, aspirin is a weaker analgesic than that. Because, and also the side effects also, when compared to morphine, no dependence is seen with aspirin. However, it effectively relieves the inflammatory pain, tissue injury related pain, and integumental pain, but it is relatively ineffective in severe visceral and ischemic pain, cannot be diminished by the use of aspirin. And the analgesic actions mainly due to the obtunding of peripheral pain receptors and the prevention of prostaglandin-mediated sensitization of the nerve endings. And anti-inflammatory action is exerted at high doses, and signs of inflammation like pain, tenderness, swelling, vasodilation, leukocyte infiltration also suppressed. These are the actions of prostaglandins. They are suppressed by the aspirin. Okay. So in every organ, there is an action for aspirin. Second is GIT action, that is in the gastrointestinal tract. There is a phenomenon called ion trapping. Ion trapping means when orally given some acidic drugs, they will not be ionized. That will be learned later. I will tell you in the next slide, upcoming slides. Ion trapping phenomenon that is seen because we are okay. That I will tell later. Now coming to the GIT action, salicylic acid is released from aspirin, irritate the gastric mucosa and cause epigastric distress, nausea, and vomiting. Due to the acidic pH in the stomach, as an acid, salicylic acid is seen in the non-ionizable form. So it can penetrate the cell membrane and enter the gastric cells. And inside the gastric cells, there is normally an alkaline pH is there. So this penetrated aspirin cannot come out of the cell. It will be staying there in the cell. That's what we call as ion trapping. Ion trapping. Okay. So that is what we see in the next line. That is, aspirin remains unionized and diffusible in the acidic gastric juice. But on entering the mucosal cell, it ionizes and becomes indiffusible. I.e., only ionizable drug, non-ionizable drug or lipid-soluble drugs can enter the cell. Ionizable drugs are usually water soluble. They cannot enter or leave the cell. And after entering the cell, the pH is not acidic inside the cell, no? So this ions get trapped. So as it cannot come out of the cell because it is not ionized there. Okay, because of the alkaline pH, acidic drug will be ionized and it cannot escape the cell membranes. So this ion trapping in the gastric mucosal cell enhances the gastric toxicity. And also it can cause focal necrosis of the mucosal cells and capillaries. Acute ulcers, erosive gastritis, congestion, and microscopic hemorrhages can also be produced in the gastrointestinal tract. Next is action on the blood. First is aspirin, even in the small doses, it can irreversibly inhibit the thromboxane A2 synthesis by the platelets, thereby preventing its aggregation effects on the platelets. Platelets have aggregation effect. That is, platelets will aggregate and produce thrombus. Okay, that's the initial hemostatic mechanism. After injury, what happens is platelet aggregation will occur. Adhesion is with platelet with other cells or endothelial cells is what we call as adhesion, and platelet with platelet is called aggregation. So thromboxane A2 helps the platelet to aggregate, thereby inhibit so the inhibition of thromboxane A2 synthesis will cause the platelet will cause the platelet not to aggregate. So it interferes with the platelet aggregation and bleeding time is prolonged to nearly twice the normal value. So bleeding will occur. And long-term intake of large dose decrease synthesis of clotting factors in liver and it also predisposes to bleeding. Okay, that is two mechanism is there for bleeding induction. First is by inhibiting the thromboxane A2 synthesis by platelet. So it prevents the aggregation of platelets. Second is some of the clotting factor production in liver is also inhibited when large doses of aspirin is intaken for a long time. Okay. And other effects of high doses or toxic doses or anti-inflammatory. That is, aspirin has 3 doses are low dose having anti-platelet effect. Next dose is medium dose will provide antipyretic action, some amount of anti-inflammatory, antipyretic analgesic action will be provided by a medium dose, and high dose can cause anti-inflammatory reactions. Anti-inflammatory doses are called high doses. Okay, so next is also high dose of cellular metabolism is enhanced and especially in skeletal muscle, glucose utilization is increased, resulting fall in blood glucose levels, especially in diabetes. This occurs with the high dose of aspirin. What happens is hypoglycemia can occur due to the increased utilization of glucose. Hypoglycemia can result with high doses of aspirin, and liver glycogen is also depleted. Next is respiration is stimulated by the direct action on respiratory center as well as due to increased carbon dioxide production also. Respiration is stimulated. And aspirin as such is not having any direct effect on heart or circulation, but doses which enhance the metabolic rate increases the cardiac output also. And it interferes with the urate excretion. So it cannot be used in gouty arthritis. We can use use aspirin for many inflammatory reactions like arthritis, but for gouty arthritis we cannot use aspirin. Why? Because it interferes with the urate excretion, thereby causing the accumulation of urates and leading to gout. For high doses, this will not occur. It will promote the excretion of uric acid, but we do not use for such high doses for this particular gouty arthritis. So it is not commonly used for gouty arthritis. Now let's make it a brief based on the dose. So low dose aspirin means 40 to 325 milligram. It will selectively inhibit the COX-1, inhibition of platelets, so inhibition of thromboxane A2 in platelets, thereby providing an anti-platelet action. Next is a medium dose, that is about 700 to 800 milligram. It provides analgesic and antipyretic action. High dose, that is 3 to 5 grams. It is mainly having anti-inflammatory action. Arthritis, Kawasaki disease, and acute rheumatic fever, we can use high doses of aspirin. Okay. So, the pharmacokinetics. Pharmacokinetics means what the body does to drug. That's what we call as pharmacokinetics. Right? That's a metabolism of drug. Maybe pharmacokinetics means ADME study also. Why? Because when we take a drug will be absorbed, distributed in the body, it will be metabolized and finally excreted. Okay. So first of all, oral administration of aspirin, it will be absorbed in stomach and small intestine. It is almost 80% plasma protein form, and it will get rapidly deacetylated in gastrointestinal wall and liver, and finally it will be eliminated from the urine. Now coming to the adverse effect that we can mention by a mnemonic aspirin itself. So making this type of mnemonics will help you a lot in the exams, because we will not forget, because the name of the drug itself is the mnemonic. First is asthma. Why asthma? Because we have already mentioned that this arachidonic acid undergoes metabolism by the action of two enzymes. COX pathway is there, LOX pathway is there. So when the COX pathway is inhibited, naturally this will go to more towards the LOX pathway. Thereby, so LOX pathway, when it is promoted more and the COX pathway is inhibited, LOX pathway will be given more. So that will lead to leukotriene synthesis. Slow reacting substances of anaphylaxis are produced. Leukotrienes, eosinophil recruitment extra will occur, and that will lead to asthma. So asthma is one of the side effects of aspirin. Second is salicylate intolerance. That is ototoxicity is seen. Ototoxicity is associated with aspirin also. Next is peptic ulcer, intestinal or gastrointestinal bleeding, Reye's syndrome. Idiosyncrasy, that is idiosyncrasy, the cause is unknown, and noise or tinnitus in high doses. That is what we call as ototoxicity or salicylism. Okay. So gastrointestinal disturbances, especially in gastric bleeding, in high dosage, it can cause salicylism. Salicylism means ototoxicity or hearing impairment, tinnitus, that abnormal sounds will be heard, vertigo, reduced hearing, allergic reactions occasionally, and sometimes renal toxicity can also occur. Next is a potentially fatal Reye's syndrome. Reye's syndrome means when aspirin is given to children in viral infection, serious liver damage will occur. Encephalopathy and liver disorder will occur in children. That's what we call as Reye's syndrome. So it's a potential complication of aspirin. And at therapeutic doses that we have already mentioned, it can impair the urate excretion, thereby causing hyperuricemia, promoting gout. That's why it is not used in gouty arthritis. Also, it will prolong the bleeding time by two actions. First is inhibition of thromboxane A2 synthesis and preventing the aggregation of platelets. Second is some amount of clotting factors will be reduced due to the liver impairment. Next is the things we see in aspirin poisoning, that is nausea, vomiting, hypothermia can be seen, bleeding, ototoxicity, and high doses. We can see hypoglycemia because of the impaired glucose metabolism. We can see hypoglycemia. Respiratory alkalosis, that is due to high anion gap metabolic acidosis will occur. As a compensatory mechanism, we can see respiratory alkalosis, and after that, it will progress to high anion gap metabolic acidosis. High anion gap metabolic acidosis. And the drug of choice for aspirin poisoning is sodium bicarbonate. When we cannot abort the action of aspirin by sodium bicarbonate, hemodialysis can be done. So these are the therapeutic uses. As an analgesic, we can use antipyretic, for acute rheumatic fever, rheumatoid arthritis. Okay, these are the doses. And nowadays, we will prefer newer NSAIDs for the rheumatoid arthritis. And acute rheumatic fever also, severe cases, corticosteroids are acting faster because the total arachidonic acid synthesis itself is inhibited by the action of corticosteroids. Also in osteoarthritis, it affords the symptomatic relief, but paracetamol is the first choice analgesic for osteoarthritis. And post myocardial infarction and post-stroke patients, we can give low dose of aspirin for the antiplatelet action. It can prevent the further recurrence of myocardial infarction, stroke. And prevention of preeclampsia, that is high blood pressure in case of pregnancy, that is also abolished by the use of aspirin. It is administered from the 12th week of gestation till the childbirth. Next is paracetamol. The second group of drug that is very important for exam point of view is paracetamol or acetaminophen. They are involved in the para-aminophenol derivatives. It is de-ethylated active metabolite of phenacetin that was also introduced in the last century, but it has come to use commonly by 1950. Now coming to the actions of paracetamol, the central analgesic action of paracetamol is like aspirin only, but it raises the pain threshold. The threshold for exhibiting the pain is raised by aspirin, thereby providing it with an analgesic action. And it has a weak peripheral anti-inflammatory component. And analgesic action of aspirin and paracetamol is additive. That is, when given together, they will provide more symptomatic relief from pain. And paracetamol is a good and promptly acting antipyretic. That is having poor anti-inflammatory action, but also the side effects are also less. And paracetamol has negligible anti-inflammatory action and it's a poor inhibitor of prostaglandin synthesis in peripheral tissues. But more active one, as I have already mentioned, COX-3 activity in brain is reduced by the use of paracetamol. And it is not able to inhibit COX in the presence of peroxides, which are generated at the sites of inflammation. Okay, that's why it is having a poor anti-inflammatory action. That is, action of paracetamol is prevented by the presence of peroxides which are generated at the sites of inflammation. Chemical mediators of inflammation, they will inhibit the action of paracetamol, thereby inhibiting the paracetamol. And the ability of paracetamol to inhibit COX-3, that's an isoenzyme of COX enzymes, would account for its analgesic antipyretic action. Then coming to the advantages of paracetamol over aspirin. First of all, aspirin is an irreversible inhibitor of COX enzymes. That is, both COX-1 and COX-2 are irreversibly inhibited by aspirin. That action is not seen by paracetamol. Paracetamol spares COX-1 and COX-2 and only inhibit the COX-3 enzyme. So it has better advantage than aspirin. Okay, so in contrast to aspirin, it does not stimulate respiration or affect the acid-base balance. High anion gap acidosis is seen in aspirin use, but it is not seen in paracetamol. And it does not increase the cellular metabolism, so hypothermia risk is also abolished. And it has no effect on CVS. And gastric irritation is also insignificant. Only COX-3 is inhibited, that is seen in brain only. And mucosal erosion and bleeding only occurs rarely only. And it does not affect the platelet function. So clotting factor function or platelet function is not seen. So bleeding risk is also less. And it is also not uricosuric. So we can give it for the gouty arthritis patients also. We can give, not for gouty arthritis, so no anti-inflammatory action. But it is not uricosuric. It will not inhibit the excretion of uric acid. So no gout production is there. Now coming to the pharmacokinetics. Pharmacokinetics means what? It is the thing that body does to the drug. So it is usually well absorbed orally, and about 1/4 of the protein, 1/4 of it is protein bound in plasma, and it's uniformly distributed in the body. And metabolism occurs mainly by conjugation with glucuronic acid and sulfate. And the conjugates are usually excreted rapidly in urine. And the plasma T half is 2 to 3 hours. And effects after an oral dose last for about duration of action is about 3 to 5 hours. Coming to the adverse effects, in isolated antipyretic doses, paracetamol is safe and well tolerated, but nausea and rashes can occur rarely. And acute paracetamol poisoning usually occurs in children who have low hepatic glucuronide conjugating ability. Why this glucuronide conjugation is the main way of excretion for paracetamol, and it is less seen in children. Small children do not have the ability to ability for glucuronide conjugation. So the metabolism of paracetamol will be delayed, and so it will result in toxicity. And if large doses are taken, serious toxicity can occur. And fatality is common more than 25 milligram, 250 milligram per kilogram of weight. And why this toxicity occurs with paracetamol? Because of a minor metabolite produced after the metabolism. That is NAPQI, N-acetyl P-benzoquinonimine. It's a highly reactive minor metabolite of paracetamol, which is detoxified by conjugation with glutathione. That we have already mentioned, this ability is seen less often in children. That's why more toxicity reaction occur with children. And with a very large dose of paracetamol, when it is taken, glucuronidation capacity is saturated. The amount of enzyme required to metabolize the paracetamol or paracetamol metabolite is reduced. They will get saturated. No more enzyme will be available. So the metabolite is seen in excess, thereby resulting in toxicity, and it will bind to the renal tubules, causing renal tubular necrosis and renal toxicity. So renal tubules also, hepatotoxicity is the main side effect of paracetamol, hepatotoxicity in high doses. Now, what's the treatment for poisoning? If the patient is brought early, vomiting can be induced and gastric lavage can be done. And activated charcoal is also given orally. And specific antidote for paracetamol poisoning is, that's very important for MCQ point of view, N-acetylcysteine. N-acetylcysteine is the antidote for paracetamol poisoning. Sodium bicarbonate for the aspirin poisoning. Now, it's the most commonly used over-the-counter analgesic for headache, mild migraine, musculoskeletal pain, dysmenorrhea, etc. And it's a first choice analgesic for osteoarthritis. So, we use paracetamol for osteoarthritis. Okay. Also, it is the best antipyretic in children. Why? Because the risk of Reye syndrome is not associated with paracetamol. It is only seen with aspirin. So, in viral fever, when aspirin is given, serious liver injury will occur due to Reye syndrome. It's not seen associated with paracetamol. So, paracetamol is the best drug to be given as an antipyretic in small children. Now, coming to the second question, that is bioavailability and the factors affecting bioavailability. And we will discuss in brief about plasma half-life also. Okay, it's very important. Everything in general pharmacology is important. These are some of the questions I have seen repeatedly in some of the question papers. So I have mentioned it here. Coming to bioavailability. So bioavailability, it is the fraction of the drug that reaches the systemic circulation following administration by any route. One important point to remember is it's a fraction of drug. Sorry, I missed it, but it's a fraction of the drug that reaches the systemic circulation unchanged, following administration by any route. That means when given orally, a drug is given orally, it undergoes some first pass metabolism, a thing called first pass metabolism. I drug undergoes certain change inside the body. But what is bioavailable means the drug which is given orally or any route that is available unchanged for its action. Unchanged is an important point here. So it is a fraction of the drug that reaches the systemic circulation unchanged following administration by any route. That's a proper definition. And so in case of oral route, we have first pass metabolism. First pass metabolism means when a drug is taken orally, it passes through several barriers. When it reaches the stomach and finally the intestine, it will go through the portal vein to the liver. Liver, it undergoes some amount of metabolism. And after that, from the liver, via the inferior vena cava, it goes to heart. And from the heart, it goes to different parts of the body. By its pathway through this GIT, liver, and then to heart, it loses some amount of drug. I.e., when 100 milligram, for example, when 100 milligram of the drug is administered orally, sometimes only 40 milligram will be present in the plasma after the first pass metabolism. 60 is lost due to this first pass metabolism. That's the main disadvantage of the oral route. But in case of IV route, when we administer a drug via IV, what happens is it's directly available to the blood. So 100% of the drug is available for action. That's why we are calling it as IV route is having 100% bioavailability. For other routes like other parenteral routes are also is mainly used to avoid the first pass metabolism and partial absorption of the drug. So IM and subcutaneous is also almost completely absorbed. Not 100%, but more than or equal to 75% is absorbed by means of IM and IV route. Okay. So bioavailability as a formula is AUC. AUC means area under the curve. This is what we call area under the curve. Okay. This whole area under the particular curve. AUC, that is area under the curve for oral route divided by AUC of IV route. Why IV route? Because 100% bioavailability is available. Bioavailability is therefore IV route. So it will be taken to the denominator portion. Okay. That's what we call as bioavailability. And how we measure bioavailability? After the ingestion of drug, we'll take the plasma levels. Plasma levels will be taken every 5 minutes or so and check for the maximum plasma concentration. And we will calculate the area under curve by dividing it like this intervals. Otherwise, we cannot measure the area properly under this curve. So we will divide it. So we will divide this curve into different trapezoids, trapeziums, and we can calculate the area under this every trapezium and thereby take the area under the curve properly. Okay, we divide it into trapeziums. Next is bioequivalence. What is bioequivalence? It is the comparison of bioavailability of different formulations of the same drug. For example, take paracetamol. Paracetamol is available in the medical store for different brands of paracetamol. For example, Crocin, Dolo, etc. are available. Okay. So due to the preparation methods, difference in preparation methods, bioavailability of different brands of paracetamol may not be the same. But some amount of difference is acceptable. We can use Crocin for Dolo, anything like that. Crocin is a brand of paracetamol. Dolo is also another brand of paracetamol. We can compare the bioavailability. If the bioavailability is within the range of 25%, it can be, the different brands can be interchanged. If the bioavailability of Crocin is say 80% and bioavailability of Dolo is maybe 100%, then we can use, because there is some difference of 20 only. So we can use take different brands of drugs. But this is not the case for low therapeutic margin, narrow margin drugs. For example, digoxin, phenytoin, etc. We cannot interchange the brands because of the difference in bioavailability. That is, in short, comparison of bioavailability of different formulations of the same drug, right? Different brands, the bioavailability when it is compared, that is what we call as bioequivalence. Next is the factors affecting bioavailability. Bioavailability, the factors affecting bioavailability means these factors also affect the absorption of the drug. For the pharmacokinetic study, we have 4 parameters. First is the absorption of the drug. Second is the distribution of the drug. Third is the metabolism of the drug. Fourth is the elimination of the drug. For absorption, the main parameter is bioavailability. And for distribution, the main parameter involved is volume of distribution. For metabolism and elimination, the main parameter is clearance. Okay. So coming to the factors affecting bioavailability, that means it also affects the absorption of the drug. So first is the disintegration and dissolution time. Drug taken orally, it should break into individual particles for the body to absorb, and it should dissolve in the gastrointestinal fluids also to make its action on our body. And for subcutaneous and intramuscular administration, the drug should dissolve in tissue fluids for its action. And also, liquids are more readily absorbed than the solid drugs, solid formulations, and poorly water-soluble drug, they are less absorbed due to delay in disintegration. They will take more time to disintegrate and dissolve. So it will take more time to make it bioavailable. The next factor is the formulation. Sometimes for the desired absorption, we will add some diluents like starch. That will also delay the absorption of that particular drug. Next is the particle size. That's why common sense we know that small particle size will definitely increase the absorption. For example, corticosteroids, digoxin, etc. And if the drugs are not meant to be absorbed, the site of action is intestine. For example, it has to remain as such in the intestine for its action, for its particular localized action. For such type of drugs, the particle size should be increased. For example, antihelminthics, because its site of action is intestine and it should remain there for its action. So such drugs are not meant to be absorbed. So it is made in large particle size. Next is lipid solubility. Lipid solubility will obviously increase the absorption. Why? Because of the permeability of the permeability associated with the membrane. Because phospholipids and they are phospholipids of the cell membrane, they will allow the drug to get involved in the cell. So lipid solubility is also a factor for the bioavailability. Next is pH and ionization. Okay. First of all, we have usually most of the drugs are either weak acids or weak bases, and they are ionized. They are most commonly occurring in some ionized form. Okay, and ionized form is also there. Some amount of drug will be ionized, and some amount of drug will not be non-ionized. Okay, so when for weak acid drugs, weak acid drugs in acidic pH, that is pH less than 7, what happens is they remain unionized and they will be lipid soluble. For likewise, the weak basic drugs, when in basic pH, that is more than 7, they remain unionized. But the reverse will also happen. That means when acidic drugs are occurring in a basic pH, they will remain ionized. They will remain as ions. Okay. So most of the drugs, they are weak electrons. So the pH is of importance here. What do you mean by pK value? pK value means the drugs, most of them are existing in both ionized and non-ionized form. When the ionized form and non-ionized form exist in 50-50 combination, i.e. the drug is 50% ionized and 50% non-ionized, it is called pK. That particular pH is called pK pH. So pH is important. When for a weak acidic drug, for the proper absorption, the pH should be acidic, i.e. less than 7. For weak basic drug, the pH should be above 7 for its proper absorption. I.e., it will remain non-ionized and lipid soluble in case of that particular type of pH. Okay. So that's what we are telling in the next sentence. That is, acidic drugs remain non-ionized in stomach. Why? Because of the acidic pH. But strong acids and base drugs, they are not involved. They are not influenced by the pH. That's the importance. Only weak acid drugs and weak basic drugs are influenced by the pH, and their absorption is influenced by the pH change. Okay. Ion trapping that I have already mentioned in aspirin. So basic drugs when given IV may diffuse from blood to stomach. Because of the acidic pH, it gets ionized and it will enter the cell and stay trapped there. That's what we call as ion trapping. And strong acids and bases are highly ionized and therefore poorly absorbed. Heparin and streptomycin, they are not influenced by the change in pH. Okay. Next is area and vascularity of the absorbing surface. Most drugs are absorbed from the small intestine because small intestine is having microvilli and therefore absorption will be more due to the increase in surface area. Next is GI motility. If gastric emptying time is faster, the passage to intestine is faster and drug will be absorbed in a faster manner. Also diarrhea, increased motility will be there. So time for absorption is not present. So absorption will be delayed in case of GI motility. Next is presence of food. Sometimes when food is present in our stomach, it helps delays the gastric emptying. That we have already mentioned. Increased gastric emptying will increase the absorption of drug, but delayed gastric emptying, it will dilute the drug and delays its absorption. And drugs form complex with some food constituents. For example, tetracyclines, they will chelate the calcium in food. So tetracyclines is not given along with food. Okay, so it will chelate calcium and some drugs are more absorbed in empty stomach. For example, ampicillin, roxithromycin, it is to be taken in an empty stomach to prevent its delayed absorption. Next is diseases like malabsorption syndromes, echlorhydria, that is reduced acid production in the stomach. It will delay the absorption and bioavailability of the particular drug. Next is metabolism. Metabolism, some drugs gets degraded in the GIT. For example, when peptide hormones like drugs, they are not given orally because of the gastrointestinal degradation of such drugs. Okay. For example, degraded in GIT, for example, insulin and nitroglycerin. Insulin is a peptide hormone. And so it will need higher doses of alternate routes. Either we have to give it in a higher dose, much higher dose, and for alternate routes like parental routes should be taken for such type of drugs. Next is plasma half-life. What is plasma half-life? Plasma half-life, it is a time taken for the plasma concentration of the drug to be reduced half to its value. If initial dose of drug is 100 ml, the time taken for the plasma concentration of the drug to become 50 or it reduced by half. In what time? That is what we call as plasma half-life. What's the significance of plasma half-life? Plasma half-life determines the duration of action of the drug. Duration of action. Because if a particular drug is having long plasma half-life, what happens is the duration of action of drug will be more. And the frequency of administration. Plasma half-life, it is less. We have to frequently administer that particular drug. And the time needed for action and to calculate the loading. Loading means initial dose that is provided to maintain a steady state plasma concentration. That's what we call as loading dose. To achieve a steady state concentration in the plasma. Maintenance is to maintain that particular dose, we are given additional doses. That is what we call as maintenance dose. To determine the amount of loading and maintenance dose, also a plasma half-life is coming into value. Next is the factors influencing the plasma half-life. First factor is plasma protein binding. That is, drugs which are extensively bound to the plasma proteins, they have longer half-life. Why? Because they are bound to the plasma proteins, so delivered to the plasma very slowly. So it will increase the plasma half-life of that particular drug which is having a plasma increased plasma protein binding. Next is enterohepatic circulation. It also increases the circulation time, also influences the T half. And metabolism, faster metabolism, obviously plasma T half will be shorter. Next is tissue storage. Drugs sequestrated. Some drugs like to concentrate in some tissues, particular tissues or organs. Such drugs, plasma half-life will be longer. And next is the clearance of the drug. When the drug is cleared very fast from the body, metabolized very fast from the body, such type of drugs will have a short half-life and the dose has to be increased. Okay. Next is coming to the broad spectrum antibiotics. What are the broad spectrum antibiotics? Broad spectrum antibiotics are mainly tetracyclines and chloramphenicol. Tetracyclines and chloramphenicol. These are the two broad spectrum antibiotics. Here I am discussing mainly about the tetracyclines. Chloramphenicol is not so frequently asked, but it's also important. But mainly we have to study tetracyclines. Okay, first of all, we can classify tetracyclines. According to the action of the drugs, we can classify tetracyclines into three. First is short-acting tetracyclines. That is, T half is about 6 hours. That means they have to be given quarterly, TD. Sorry, QD. 4 times a day it has to be given. That is short-acting, 6 hour. 6th hourly we have to give such type of drugs. And next is intermediate acting and long acting. Okay, short acting we can memorize it by a mnemonic TOC. TOC means T for tetracycline, O for oxytetracycline, C for chlor-tetracycline. And intermediate acting is 12 hours. That's the T half is 12 hours. That involves demiclocycline and methacycline. Next is long acting, that is T half is about 18 hours. That is mainly minocycline and doxycycline that I learned by a mnemonic. My dog is long. So long acting, minocycline and doxycycline. Okay. Coming to the mechanism of action. So basically tetracycline, both tetracyclines and chloramphenicol, they are protein synthesis inhibitors. And for higher animals, we have 80S ribosomes, and for bacteria, we have 70S ribosomes. Okay. And usually, these cyclines, they are taken up by the susceptible microorganisms by means of an active transport, that is ATP mediated transport. By means of an active transport, this particular tetracyclines are taken up into the susceptible microorganisms cell. Okay. But they are selectively toxic to microorganisms because human cells cannot accumulate tetracycline by means of this particular action. So they are safe. And it usually binds to the 30S, that is 70S ribosomes have two subunits, that is 30S subunit and a 50S subunit. The mechanism of action of tetracycline is on 30S side, whereas in chloramphenicol it is on 50S. Okay, this 30S subunit tetracycline T40, that is tetracycline act on 30S subunit T4T and binds to the 30S subunit, and the tRNA carries amino acids to the ribosome for protein synthesis. It has three sites, one attachment site or A site, one P site and E site. Okay. And so for tetracycline, the mechanism of action is it is acting on the A site or attachment site. Tetracyclines bind to the A site and prevent the binding of tRNA to that particular site. Whereas in the protein synthesis, there is an enzyme called peptidyl transferase that will connect the different amino acids that is inhibited by chloramphenicol. Here, for that is their site of action is 50S ribosome, and the transpeptidase enzyme action is seen on inhibition of transpeptidase enzyme is seen in chloramphenicol mechanism of action. Whereas in tetracycline, we have the mechanism of action involving the 30S ribosome and it inhibits the A site or attachment site. Okay, and they are usually bacteriostatic. Next is the pharmacokinetics. Older tetracyclines, they are incompletely absorbed from the gut and the bioavailability is reduced. Doxycycline and minocycline, they are longer acting tetracyclines. Okay, my dog is long. Doxycycline and minocycline, for that, food does not affect the absorption. And tetracyclines, they chelate calcium and other metals to reduce their absorption. So they are not given along with milk, iron preparations, and antacids. Okay. Antacids, usually what happens is antacids will raise the pH. It will make the pH of the stomach to an alkaline pH. And also, these tetracyclines, they undergo enterohepatic circulation. And tetracyclines like oxytetracycline and doxycycline can be given. Most commonly given tetracycline nowadays is doxycycline. And it can be given IV, but it can irritate. But it can irritate also. Thrombophlebitis can also occur in case of IV injection of oxytetracycline, doxycycline. And intramuscular injection, obviously, they will be very painful, very painful. So usually they are avoided in case of tetracycline administration. And tetracyclines, they are excreted through kidneys, but two types of tetracyclines like doxycycline and minocycline, long-acting tetracyclines, they are excreted via GIT. So the tetracyclines which are safe in renal insufficiency is doxy and minocycline. Next, coming to the adverse effects. First is gastrointestinal irritation, nausea, vomiting, diarrhea. Everything we can write this nausea, vomiting, diarrhea, most of the drugs. That's one of the favorite adverse effect of all students. And next is hepatotoxicity. It can result in jaundice, and acute hepatic necrosis may occur in pregnant women, but it's also a rare complication. And renal failure may be aggregated. And outdated tetracyclines can cause Fanconi syndrome. Okay, Fanconi syndrome means kidney damage occurring due to the metabolites of outdated. Outdated means expired tetracyclines when we use. It can lead to kidney damage, leading to Fanconi syndrome. That's what we call as Fanconi syndrome. Next is phototoxicity, skin reactions and dermatitis. On exposure to sun, some rashes may occur. That is what we call as photosensitivity associated with, more likely it is associated with doxy and demiclocyclines. Next is, we always study about the tetracycline's effects on teeth and bones. Okay, because of the chelating effect of tetracycline, chelation of calcium with tetracycline. The reason for that particular reaction is calcium tetracycline. Okay, the reason is calcium tetracycline orthophosphate complexes get deposited in the developing teeth and bones, and the deformities depend on the time of administration. Time of administration means which part of the development of tooth we administer tetracycline, that will affect the teeth. Okay, earlier the more will be the damage. Next is super infections. As we all know, the broad spectrum antibiotics that can suppress the normal GAT flora, thereby leading to super infections. Next is hypersensitivity reactions. They are not common. And local IV injections, it can cause thrombophlebitis or irritation. Next is what we call as pseudotumor cerebri. Pseudotumor cerebri means it can increase, that is tetracyclines, it can increase the intracranial pressure, especially in infants. In infants, it results in the bulging of anterior fontanelle, giving a false impression of a tumor. That's what we call as pseudotumor cerebri, which is an important adverse effect of tetracyclines. In adults, it can cause headache. Okay, the fontanelle is closed in adults, so it can cause headache in adults due to the increased intracranial pressure. Next is anti-anabolic effect. When large doses are given for long periods, it can increase the urinary excretion of nitrogen by an anti-anabolic effect. Next is, it can be used, tetracyclines are the drugs of choice in rickettsial infections. Okay. And chlamydial infections, atypical pneumonia due to mycoplasma pneumonia, cholera, brucellosis, plague, etc. For plague, we can use tetracyclines in combination with aminoglycosides. Okay. Other infections like traveler's diarrhea, sexually transmitted diseases like syphilis, gonorrhea, chancroid, It's not preferred, but it can be given. Usually, for syphilis, we will give penicillins. It can also be given. Tetracyclines can also be given. For acne, we can use minocycline combinations. Minocycline can be used for acne. Low doses are given. Tularemia and other infections in the treatment of Lyme's disease, relapsing fever, leptospirosis, and PEP of anthrax, post-exposure prophylaxis of anthrax. And also protozoal infections like amoebiasis, malaria. Usually for malaria, doxycycline is given along with quinine in multi-drug resistant malaria. And for syndrome of SAADH, that is syndrome of inappropriate secretion of ADH also, we can give tetracyclines because particularly demiclocycline, it can inhibit the action of ADH, thereby abolishing syndrome of inappropriate ADH secretion. It is SIADH. For SIADH, we can give demiclocycline. Coming to the contraindications. Contraindications that is strictly prohibited in pregnancy, lactation, and children up to 8 years of age because their effects on teeth as well as on bones. When given to children under the age of 8 years, stunted growth due to the action on bones, stunted growth can occur, and risk of acute hepatic necrosis is seen in, that is liver to hepatotoxic reactions can occur in pregnant women, and also risk of pseudotumor cerebri that I have already mentioned due to the rise in intracranial pressure, the bulging of anterior fontanelle, that's what we call as pseudotumor cerebri. And it should be cautiously used in renal and hepatic impairment. Dose reduction should be made. Now coming to the anti-tubercular drugs and the mechanism of action and characteristic adverse effect I'll mention. Okay, we know that there are two first line and second line anti-TB drugs. Here we are going to enumerate the first line drugs. That is HERS. HERS means basically 5 drugs are there. Streptomycin is nowadays using as a supplementary drug that for the replacement of these 4 or some other drugs. Nowadays used as a supplementary drug. And the main anti-TB drugs, first line drugs are isoniazid H, rifampicin R, pyrazinamide Z, ethambutol E, and streptomycin S. Okay. These are the second line drugs. Now coming to the INH. INH means isoniazid or H. That's the most effective and cheapest primary anti-TB drug. It is tuberculocidal for rapidly multiplying bacteria, but static for resting bacilli. It is static in action. Okay. It destroys both intracellular and extracellular organisms. That is, TB can be seen intracellularly inside the macrophages and extracellularly inside the cavities. Okay, so it can destroy both of them. That is, intracellular bacilli, as it freely penetrates into the cell. It can freely penetrate inside the macrophages, thereby killing the tubercle bacilli inside the cell. And bacilli multiplying in the walls of the cavities, that is extracellular organisms. So it is effective against both intra and extracellular organisms. Whereas pyrazinamide, it is for the intracellular organisms only. Extracellular organisms are not affected by pyrazinamide. Okay. Now coming to the mechanism of action. The cell wall of mycobacteria. What's the mechanism of action of this anti-TB drugs? Not anti-TB drugs, INH. The cell wall of mycobacteria, it contains a large amount of mycolic acid. So it is an essential component of mycobacterial cell wall. And it freely enters the mycobacteria and it is converted to an active. So it's a prodrug. It is converted to its active form by an enzyme called catalase peroxidase present in the mycobacteria itself. So mycobacteria, inside the cell of mycobacteria, we have catalase peroxidase enzyme that will allow to activate the INH. INH is a prodrug and it is activated inside the mycobacteria by means of an enzyme, catalase peroxidase. And the active form, it covalently binds certain enzymes which cause the cell wall synthesis inhibition. That's mainly DHFR, dihydrofolate reductase enzyme, and thereby inhibits the mycolic acid synthesis and the cell wall formation. And so resistance of INH, in most of the drugs, resistance can be seen associated. That's why we are giving multi-drug therapy for TB in order to prevent the development of resistance. Resistance to INH is seen when there is overproduction of the enzymes. That is, some of the enzymes, they are degraded by this activated form of INH. So bacteria will produce extra amount of enzymes so that the functions can be done properly. So resistance to this particular drug, that is INH, is made by the overproduction of the enzymes that are inhibited by INH. Coming to the pharmacokinetics, it is completely, these are all oral drugs. Whereas streptomycin can be given in other parental routes, but rest other drugs are usually given orally. And INH is completely absorbed orally and penetrates all tissues, tubercular, that is for extra as well as intracellular organisms, it is effective. And it is metabolized by acetylation. And it is genetically determined. There is a significance for this acetylation reaction. That is, some patients, they are genetically determined that they are slow acetylators and fast acetylators are there. And for slow acetylators, the drug toxicity will increase because of the slower metabolism of INH, whereas fast acetylators are always at a risk of resistance development. Okay. And peripheral neuropathy is the main side effect of INH, that is increased in case of slow acetylators because of the increased state of the drug inside the body. Peripheral neuropathy is commonly seen in slow acetylators, and hepatotoxicity is most commonly seen in fast acetylators. If INH is given once weekly in fast acetylators, adequate therapeutic concentrations may not be attained. I.e., the metabolism of drug will happen in a fast manner, so we cannot give it once in a week because of the rapid metabolism of the drug. And the metabolism of INH, usually metabolites of INH is excreted via the urine. And usually, what are the adverse effects of INH? First of all, main adverse effect is peripheral neuritis. It is usually related with vitamin B6 because of the increased utilization of the vitamin B6. Vitamin B6, that is pyridoxine deficiency, will arise. So we have to supplement pyridoxine from the outside. That is usually 10 milligram is given for prophylaxis. And hepatitis, it is more commonly seen in alcoholics and in elderly patients. In some patients, hepatic necrosis with nausea, vomiting, and jaundice can be seen associated with INH. And CNS toxicity, including psychosis and seizures. Usually, this is because of the action of GABA. GABA means it's an inhibitory neurotransmitter, which is inhibited by INH. So, seizures, risk of seizures, psychosis, etc. are seen in, that's more commonly associated with epileptics. And anorexia, GIT discomfort, fever, allergic reactions are there. Also, hemolysis is increased in case of G6PD deficiency. G6PD is a glucose 6-phosphate dehydrogenase enzyme. That's an important enzyme for the protection of our blood cells, red blood cells from the complement system. Normally, in our body, there is complement system. It will attack everything. So for the protection of our own cells, certain enzymes are there in different parts of the body. So G6PD enzyme is for the protection of red blood cells against the complement attack. So if the G6PD deficiency is there, then what happens is hemolysis will occur due to the damage to RBCs. Next is rifampicin. Rifampicin is otherwise called rifampin. Okay. So it's a highly effective tuberculocidal drug. It's a cidal drug, and it's only a drug that acts on persisters. That means most of the some bacteria will persist even after aggressive drug therapy. Such persisters will be killed by rifampicin. That's why we are giving multi-drug therapy to tuberculosis patients in order to prevent the resistance, drug resistance. Also, for the persisters, we can give rifampicin. Rifampicin plus INH combination can be given. In this also, both intracellular and extracellular organisms, they are killed, and it is effective against tuberculosis bacilli resistance to other drugs. If used alone, these drugs will cause resistance, development of resistance. That's why we are giving it in a combination. Coming to the action, mechanism of action of rifampicin, it's very simple. We can remember R for R. That is, rifampicin, it inhibits the RNA polymerase, DNA-dependent RNA polymerase. Rifampicin, RNA polymerase inhibition. So, it will inhibit the RNA synthesis. Rifampicin, RNA synthesis inhibition. It's a bactericidal drug. And in therapeutic concentrations, rifampicin cannot bind to human RNA polymerase. So, that is for our cells. This nil, almost nil. And so it will selectively destroy the bacteria. Coming to the pharmacokinetics, it's well absorbed and has good tissue. It's given orally. It is well absorbed and it has a good tissue penetrability, reaches the caseous material. Usually seen in TB, we can see caseous material. Caseous necrosis is seen in TB. Cavities, macrophages and CS. It also appears in saliva, tears and sweats. It can stain the secretions. It can be considered as an adverse effect or side effect, but it's useful also. We can verify whether the person is taking the drug or not by staining of the secretion. If staining is seen, that means the patient is taking the drug. Okay, so it's of some advantage to us. And it's a microsomal enzyme inducer. So it promotes the metabolism of certain other drugs. So numerous drug interactions are commonly seen with rifampicin. Coming to the adverse effects. Just a minute. Just a minute. Coming to the adverse effects of rifampicin. First is hepatotoxicity. Gastrointestinal disturbances like nausea, vomiting, diarrhea, and flu-like syndrome characterized by fever, body ache, and chills, and CNS symptoms that include headache, drowsiness, dizziness, ataxia, confusion, etc. And pain and numbness in extremities and muscle weakness have been reported. And also hypersensitivity reactions can be seen. And next is staining of secretions that I have already mentioned. It will stain the tears, saliva, sweat, and orange-red color. So it is difficult for the patient, for us, but for us it's of advantage because we can ensure that the patient is taking the drug properly so that the secretions are stained. Coming to the drug interactions, the main drug interactions are aminosalicylic acid may delay the absorption and reduce the bioavailability of rifampicin. So it should be avoided giving with this drug. And rifampicin is a microsomal enzyme inducer. So it will increase the metabolism of anticoagulants, hormonal contraceptives. So contraceptive failures, anticoagulant failures, etc. can be seen. Ketoconazole, that is an antifungal drug. Cyclosporin, in transplant patients we will give cyclosporin, and some anticonvulsants and antiretroviral protease inhibitors. They are easily metabolized, so their action is abolished or minimized by the usage along with rifampicin. Next is main uses of rifampicin, that is in tuberculosis and atypical mycobacterial infections we can give, for leprosy, prophylaxis of Haemophilus influenza and meningococcal meningitis in close contacts, particularly in children. And for resistant staphylococcal infections also we can give it along with the beta-lactam antibiotic like penicillin, cephalosporins, that group of drugs, or vancomycin. And for brucellosis, pneumococcal meningitis, if usually we'll give penicillin for pneumococcal meningitis, but if failure occurs, then we can treat with rifampicin along with ceftriaxone. And to eradicate the carrier state, okay, in nasal carrier state of Neisseria meningitidis, that is meningococci and H. influenza, Staph aureus, etc. To eradicate the carrier state, we can also give rifampicin. Now coming to the anti-diabetic drugs. Okay, there are basically 6 groups. First group is insulin. and 5 groups are mainly oral anti-diabetic drugs. Okay, oral hypoglycemics. Okay, and coming to the mechanism of action of some one group of drug I will mention. Okay, these are the insulins. Insulin is a anabolic hormone. Anabolic hormone. Okay, so it will cause weight gain, and insulin is always present in a basal amount. And when we eat food, what happens is the insulin spike will occur. Okay, so these are the insulins. This is the classification of insulin: short acting, intermediate acting, and long acting. Short acting, that is regular or plain insulin. Semi-lente insulin, when it is combined with zinc, we can somewhat delay the release of insulin thereby. So it is intermediate acting is insulin zinc suspension, neutral protamine heptane or isophane insulin. Long acting is ultra long, ultra for L for L, ultra. The cell should be in caps. So ultra lente, more L, so long acting. Insulin zinc suspension and protamine zinc insulin. These are the long acting insulins. Now coming to oral hypoglycemic drugs. That is the main group, or the first group is sulfonylureas. They are the oldest group of drugs. They have 2 generations. First generations, usually hypoglycemia is the main side effect of this anti-hypoglycemic drugs. Hypoglycemia is the main side effect. That is more commonly seen associated with insulin. It is less commonly associated with oral hypoglycemic drugs. Okay. The first group of drugs, they are sulfonylureas. It has first generation, tolbutamine, chlorpropamine. Second generation starts with glibenclamide, glipizide, gliclazide, glimepiride. Okay. First generation usually they ends with ide. First generation, tolbutamine, chlorpropamine, acetohexamide, tolzolamide. And second generation usually starts with at least 2 drugs you should know. 2 examples you should write in the classification. At least two. Okay. At least one, you can write 2. Usually, second generation, it starts with gli. And next is biguanides, that includes fenformin and metformin. Meglitinides, rapaglinide and natiglinide, thiazolidinediones, proglitazone, pioglitazone, rosiglitazone. That's the most common drugs. And alpha glucosidase inhibitors, that is acarbose and miglitol. Then one thing, we have 2 types of diabetes mellitus. One is first type 1 diabetes, that means insulin dependent. Insulin dependent means it's an autoimmune disease. That means insulin is usually produced by beta cells of pancreas. Beta cells are usually destroyed due to autoimmunity. Autoimmune reaction, beta cells are destroyed. So in such cases, we have to give insulin. In such cases, this oral hypoglycemic drugs are of no use. We can use acarbose and insulin. Only acarbose and insulin is given for type 1 diabetes. First, other drugs, that is other oral hypoglycemic drugs that are used for type 2 diabetes, that is insulin independent. We can use oral hypoglycemic drugs. First group is usually seen in younger age group. That is type 1 diabetes is usually seen in younger age groups, and because it's mainly due to autoimmune destruction. There is no amount of insulin is available for action such type 1 diabetics, whereas some amount of insulin is there for type 2 diabetics. So we can use this oral hypoglycemic drugs, and most of the oral hypoglycemic drugs, they require some amount of insulin for its action. That's why we cannot give this oral hypoglycemic drugs in type 1 diabetes. Okay, that's an important point. Next is the first group of sulfonylurea. We will learn in detail. Sulfonylureas, they are a sulfonamide derivative used for its antibacterial effects. So, we know that sulfonamides is a group of antibiotics. So it is first used as an antibacterial, but in typhoid. But the patients, they are seen associated with hypoglycemic effects. So we consider to use it in hyperglycemia of diabetes mellitus. So this observation led to the development of sulfonylureas. Coming to the mechanism of action. Mechanism of action, is mainly it reduces the blood glucose level by stimulating the brisk release of insulin is promoted from the pancreatic beta cells. That is, some amount of cells should be there for its action, and increasing the sensitivity of peripheral tissues to insulin, and that is sensitivity of peripheral cells. That means mainly its action is occurring in the liver. In liver, it prevents the gluconeogenesis and increasing the sensitivity of peripheral tissues to insulin, and increasing the number of insulin receptors will also be increased, and suppressing the hepatic gluconeogenesis. That is also a peripheral action, peripheral tissue action, that is action on the liver, inhibiting the gluconeogenesis of new glucose formation from the liver. Also, glycogenolysis is also inhibited by this sulfonylureas. That is, in cells, sulfonylureas bind to sulfonylurea receptors. Receptor 1, SUR1, it binds to SUR1. It leads to the inactivation of potassium ATPase dependent potassium ATP dependent potassium channels. It blocks the ATP dependent potassium channels. So the positivity of the cell increase, which leads to its depolarization and binding of the membrane-bound vesicles of insulin to the cell membrane and its release. That is, calcium influx and normal release of insulin will be promoted by the action on ATP-dependent potassium channels. Blocking of ATP-dependent potassium channels, thereby causing the depolarization of the cell and the release of insulin from the vesicles. So, we have two generations of drug in sulfonylureas. First is tolbutamide. That's a short acting and is therefore associated with lesser risk of hypoglycemia. Usually, all hypoglycemic drugs, they are usually associated with lesser risk compared to insulin. Lesser risk of hypoglycemia is seen in oral hypoglycemic drugs. And also, so it is safe in elderly diabetics. And chlorpropamide is long acting and cause prolonged hypoglycemia. Long acting means that can lead to hypoglycemic effects in particularly elderly. And tolsolamide has a slow onset of action, and use of first generation agents can result in several drug interactions. That's why we develop more drugs that is involved in the second generation. So they are more potent than the first generation drugs, but more potency means more side effects. That is, increased risk of hypoglycemia. So it should be used cautiously, particularly elderly diabetics. And it is contraindicated in renal and hepatic impairment. Glibenclamide, as I have already mentioned, the second generation agents, they usually start with gli prefix. And glibenclamide, gliburide is a commonly used sulfonylurea, second generation, and it is longer acting. So it can be longer acting means it can be given orally, OD, once daily, and it can cause hypoglycemia and rarely flushing after alcohol consumption. And glipizide, alcohol consumption, it can itself can lead to hypoglycemia. It will precipitate such episodes. And glipizide has a short T-half and food delays. It should not be given along with food, and it is less likely to cause hypoglycemia. The longer acting drug is limipiride, and it can also be given once daily. Coming to the pharmacokinetics, these are all oral hypoglycemic drugs. So it is orally absorbed and extensively bound to plasma proteins. It is usually metabolized in liver, and some amount is excreted via the urine or kidney, and it should be avoided in patients with both type of excretion is seen. So should be given caution in renal or liver dysfunction. Coming to the adverse effects, the most common what is the effect? That is hypoglycemia. When it is exaggerated, that also becomes a side effect. So hypoglycemia is seen least with tolbutamide, but this is also associated with this oral hypoglycemia is less than insulin, but still there. And nausea, vomiting, jaundice, and allergic reactions, and may have increase in rate of some amount of cardiovascular death is associated, but some studies are there. And however, it is still controversial. Okay, rate of cardiovascular is seen increase in the use of oral hypoglycemic drugs, but it's controversial. and it can precipitate disulfiram-like reactions on consumption with when given along with alcohol. Some adverse reactions, some reactions will occur. That is what we call as disulfiram-like reactions on consumption of alcohol is seen with sulfonyl ureas. And drug interactions, certain drug interactions are also seen. NSAIDs, warfarin, sulfonamides displace the sulfonyl ureas from protein binding sites. And alcohol, chloramphenicol, cimetidine, it will increase or exaggerate the hypoglycemic effect. And these drugs like diuretics and corticosteroids, they have hyperglycemic action. So this will increase the blood glucose levels, inhibit this particular type of drugs. So that's the end. So these are the most important questions. And due to lack of time, I can't mention this chloramphenicol, and some important topics are also left behind that you have to study. Okay. Main things are this beta-lactam antibiotics. Antibiotics, everything is important. And general pharmacology also is very important. Many questions are coming from that part. And also very important for that beta blockers, that ANS, some things are very important, that like beta blockers, etc. That is also seen in some question papers. Okay, so thank you. Thank you for your time. Thank you. Any doubts you can ask in the WhatsApp group. Hello? Hello? ഹലോ ഹലോ ക്ലാസ് കഴിഞ്ഞായിരുന്നു, എനിക്ക് ഒരു ഇതും കിട്ടുന്നില്ല. ഹലോ ഹലോ ക്ലാസ് ഫിനിഷ് ആയിരുന്നു. ഹലോ. ഓക്കെ ഓക്കെ.